Okay, so any questions from our section on last Thursday? Anything at all? Everyone's an endocrine expert, right? You guys can treat any endocrine condition now, pretty much, mostly. Okay, we're going to continue on talking about HIV and our different treatment regimens for that and different types of drugs we're going to be using for that. So the first one we're going to be looking at is our nucleoside or nucleotide in some cases, reverse transcriptase inhibitors. These are often called the NRTIs. These are very important because these constitute usually about 2/3 of the backbone of any HIV regimen. Okay, so these are important drugs to remember. It's not important to necessarily remember whether or not these are thymidine analogs. I only kind of include that just for completeness sake. Another thing you're going to notice when you're looking at HIV regimens is they love acronyms for their drugs. For instance, zidovudine gets abbreviated to AZT. That was like one of the first big drugs for HIV that ever came out. How they got AZT is probably from the chemical name, if I had to guess. But you can see how this could make things very prone for medical errors, right? And so if you talk to an HIV expert, they're like, oh yeah, the patient was on D4T plus 3TC, and then they're on this other thing, and it's like alphabet soup. So be very careful when you're dealing with these patients, especially if you're using acronyms, very prone to med errors. I will just have you guys be held accountable for being able to recognize the generic name. Obviously, I'll have the brand name on there as well. I'm not going to include the abbreviations for testing purposes. But anywho, so these drugs are going to be working to inhibit the enzyme reverse transcriptase, which we know is important for doing what? Exactly. So this is the stuff that's producing like the viral DNA, and which again eventually gets incorporated into the human DNA. So we like to inhibit that if possible. The way that these are going to work is that the drugs themselves have to be phosphorylated, very similar to how normal base pairs end up getting phosphorylated before getting incorporated into DNA. And so what you're going to see is that they actually will end up working as these kind of chain terminators. Essentially, they're going to sit there and sit on the end of the kind of elongating DNA chain. So I can show you. Right here, you have the enzyme reverse transcriptase, right? So it's reading the viral RNA in order to produce new DNA, right? And that's what, again, will get incorporated into the host cell, right? Into their DNA. So if instead we can incorporate something here that kind of binds onto the end of the chain and prevents further DNA elongation, then you prevent that process from occurring, and hopefully you keep that cell from being infected, right? So basically, they're lacking kind of that sugar phosphate linking bridge because, you know, again, their DNA is usually made of that kind of that sugar backbone that holds all the base pairs together. You kind of lack that, and so there's nothing that can be added on to that chain to continue that elongation. Very similar to what you see with things like acyclovir and other drugs in that kind of category, but this is working specifically against HIV. Okay, does that make sense for how that's working? All right, we're going to look at the NNRTIs, which are the non-nucleoside reverse transcriptase inhibitors. They're actually going to work on the enzyme itself, but these ones are specifically just getting incorporated into the chain, and they prevent elongation after that. So again, they're going to be affecting both the RNA and the DNA synthesis here. You're going to see that the adverse effects are typically going to be more mediated through the fact that these drugs are not going to be 100% specific for the viral DNA. This is going to be also affecting some of our human cells and components, and so the mitochondria can be affected by this as well. So especially with the older agents, you're going to see that they're going to be more have more pronounced side effects, things like stavudine, didanosine, and zidovudine. But some of the newer ones, you actually see fewer side effects. So a lot of these are getting used more frequently. So things like tenofovir and tricytidine, they're getting used much more frequently nowadays. So I remember when I was in school, we had a pharmacotherapy class where basically we had like, you know, kind of fake patients we would interview and have to come up with cases for. And so we had one guy who actually, he went to all the campuses for UF, and he had HIV. He'd had it since like the 80s. I think he'd gotten it from like a blood transfusion or something. But when he was talking about some of the side effects that he would get with some of these very old medications like didanosine, would have just horrible, horrible diarrhea associated with it. You know, things like just completely uncontrollable and just in the middle of a public, and how bad this would affect his lifestyle. And so you're noticing nowadays with a lot of the better drugs we have with better side effect profiles, these patients are getting much better quality of life out of this. This is going to be one of the things we're going to talk about, is the adverse effects. I think so important for these drugs. Okay, so some of the things you're going to see with the NRTIs, you can worry about things like peripheral neuropathies occurring. Pancreatitis can also be a potential thing here. And then you're going to see lipoatrophy that can occur, and you're going to see lots of kind of fat issues that pop up with these drugs. We'll see lipodystrophy that can occur with some of our other drugs later on, but lipoatrophy here. And then you also have to worry about things like lactic acidosis with fatty liver. So lots of problems with these drugs, but the newer ones are going to be more well tolerated. One of the special things you have to note are the drugs that require testing before use, and so abacavir is going to be one of the ones here. This is very important that you test for this HLA B5701 protein. You're testing for that to see if your patient expresses that or not. If they do, then they are much more likely to have an anaphylactic reaction to abacavir. Okay, so abacavir can be a very good drug, but if your patient is expressing that, they're much more likely to have an allergic reaction, and they should not be using that drug. Okay, so that's one kind of special case for abacavir specifically. Okay, so then we have the NNRTIs. These are the non-nucleoside reverse transcriptase inhibitors, and so instead of these being kind of chain terminators and preventing elongation of the viral DNA, instead what we're seeing here is that we're actually having the drug coming along and actually changing the conformation of the enzyme. So the reverse transcriptase here is no longer able to read basically the viral RNA, and thus no DNA can be produced at that point. Okay, so doing basically the same thing as the NNRTI is just doing it at a different site of action. So would you expect there to be any synergism between NNRTIs and the NRTIs? Absolutely, right? So when we're looking at regimens, it's important to make sure we're looking at synergism between different mechanisms of action. And so this is one of the groupings you will see is NNRTIs plus two NRTIs. We'll look at that a little bit later, so that'll make more sense. But just kind of think about the mechanisms, think about how they can kind of be complementary to one another. They say, "Hey, you look really nice today," and just kidding. Okay, make sure you guys are awake. Okay. So the drugs that fall into the NNRTI category, delaverdine, efavirenz, nevirapine, probably the ones you're going to be seeing used a little bit more frequently nowadays are going to be including etravirine and rilpivirine. Be able to recognize any of these as an NNRTI, but I just kind of note these two here because they are starting to be recommended much more frequently for kind of initial treatment of HIV. You're going to see that the recommendations change very, very frequently, and so it's really, really important that if you work with this patient population, you stay up to date on what the current recommendations are. So by the time I get to this lecture next year, this is going to be probably out of date, and they're going to have new recommendations for what's going to be kind of first line from that standpoint. So anyway, adverse effects, they're pretty well tolerated for the most part, as opposed to some of the other drugs we'll look at, but rash, have increases in your LFTs, the transaminitis can happen here. The big thing to note with these drugs is that they have kind of a low barrier to developing resistance to them, okay? So you're going to look at things that have kind of a high durability to mutations, and things that have low durability to mutations. Okay, that means that things that have high durability mean that you can have multiple mutations in the virus and they still remain effective. With the problem with some of these older NNRTIs is that you could have one mutation, one specific one in the virus, and it would immediately confer resistance against all of the NNRTIs. Okay, so for instance, if you had a patient who had a resistance developed to efavirenz, they would immediately be resistant to nevirapine. Okay, so that was kind of a problem because then once they had that mutation, then you couldn't use those drugs anymore. And so we, especially early on, in the kind of mid 90s to early 2000s, like we needed to have as big of an armamentarium as we had, but that would kind of limit us to a large degree. Things like etravirine and rilpivirine have a higher durability. They require more mutations before they lose activity. So we'll talk about resistance testing a little bit later, but just realize that these are why these are recommended more first line now because of the fact they are more durable to that. So the next group will be our protease inhibitors. These are, how do you think these work? Inhibit protease, absolutely. How do beta blockers work? They block beta, of course. Right, so these basically are once the cell has produced new viral proteins, it comes along this kind of long protein string, right? It's not active at that point. It has to be kind of cleaved up into the functional subunits, and that's where protease comes into play. So it's going to kind of come along and kind of chew it up in order to have fully functional proteins, and then that can be incorporated into that viral capsid, which can be released out into the bloodstream. So this is another very important group. This are especially some of the kind of early on, some of the more prominent drugs that we would see being used for these regimens. So again, I'm sorry for the sheer number of different drugs that are in all these different categories, but again, be able to recognize which kind of category they fall into. Because I'll have questions on the test. It'll be like, which one of these would make sense as a regimen for a heart therapy for your patient? So I'll include things like, 3 protease inhibitors, and that would be obviously not the correct answer, right? You know, things like that. I'll kind of give you some more clues on how to answer those questions correctly, but be able to recognize the drugs and what mechanism they fall into. Okay. So one of the important drugs here, you notice here, lopinavir is usually used in combination with this drug ritonavir. So you guys ever heard of the drug ritonavir before? Ritonavir is very, very important because it works as a booster to help make other protease inhibitors work better. Okay, basically ritonavir is a very, very strong inhibitor of the enzyme CYP3A4. So again, now we're going to see a lot of drug interactions come about from this group. But basically, some of the problems with using HIV medications early on in the early days of HIV is that patients were having to take just a huge, huge pill burden. They're having to take a lot of these medications multiple times a day. I don't know if you guys ever seen like videos of patients back in the day, but they would be taking like 20, 30 pills a day just to manage their HIV. So what we can do is by using the drug ritonavir for certain drug combinations, you can actually get boosted levels of the other protease inhibitor, unless you have to dose the drug less frequently, right? Because the levels stay up higher, they're not getting metabolized as quickly, and so that's why oftentimes you're going to see ritonavir in combination with one of these protease inhibitors. And so it's a very frequent combination here. As far as adverse effects go, these are really not super preferred in a lot of cases just due to the side effects associated with it. There's lots of metabolic conditions that kind of pop up from chronic use of your protease inhibitors that include a lot of GI distress. You're going to see bad effects on their lipids. So hyperlipidemia can be worsened by this. They can have worsened glucose intolerance, leading to things like diabetes popping up here. And then you also have this lipodystrophy. So this is very kind of a characteristic buffalo hump that you can see with chronic use of some of your protease inhibitors, right? And so back in the day, these patients really weren't living long enough for a lot of these other kind of secondary endocrine problems to be an issue, but nowadays their survivability is much better. Now we're having to start to deal with these kind of secondary effects and treating their diabetes and treating their hyperlipidemia. So this will become much more important, especially in the chronic term, especially if you're dealing with these guys on more of a kind of a primary care basis, right? So again, most of these are also going to be metabolized by the liver, but we mentioned either using that low-dose ritonavir, or there's another drug called cobikistat. You'll see that pop up a few other times throughout this lecture. Those are both going to be used to inhibit CYP3A4, to boost the levels of those other drugs that are metabolized by CYP3A4 and allow the drugs to last longer, right? So you have higher drug levels, so you're going to have better viral suppression. You're going to have less frequent dosing, but you also have to think about all the other drugs that could potentially interact with CYP3A4, right? So for instance, if I'm giving them a protease inhibitor and I'm worsening their lipids, what drug might I use to treat that? A statin, right? So then you have to think, okay, well, what statin can I use that doesn't get metabolized by CYP3A4? And you say something like, okay, let's try to use like rosuvastatin, right? That might be a good option to use for those patients. So think about the drug interactions. Make sure you're running those interactions online or on your reference of choice beforehand, because otherwise you can really get yourself into trouble with these. Okay. The next group of drugs, we mentioned that it's important for the virus to get into the cell. They have to undergo this fusion activity in order to incorporate itself into the cell. And so we actually have some fusion inhibitors. And so Enfuvirtide or Fusion is going to be the drug that inhibits this process. And so this is actually interesting because this one really only has activity against HIV-1, but no activity against HIV-2. So as you might imagine, depending on where you're practicing, especially if you're like wherever practicing in Africa, like this drug would never be used because HIV-2 is so much more prominent there, right? So start to think about things like activity and what drugs make sense for that group of patients. Previously, all the other HIV drugs we've been talking about are available for oral administration. This one has to be administered, bless you, has to be administered subcutaneously. So this one comes as an injection. Because it is an amino acid, it's a protein that will get torn up in the stomach acids. So it's important to make sure they're rotating their injection sites around to make sure not to inject the same spot every single time. Otherwise, they're going to have some injection site reactions and get these nodules that will form over time, which can also kind of inhibit how well the drug gets absorbed anyway. So make sure they're rotating sites appropriately. Also, more advanced HIV patients, what are they more at risk for anyway? Infections, right? So they have to make sure they're cleaning their site appropriately, make sure they're not going to get a skin infection secondary to this. So think about all those kind of things as well. Okay, next we have the CCR5 Antagonist. We mentioned that when HIV comes into contact with a cell, especially those CD4 cells, there are co-receptors that it will interact with that helps to facilitate the HIV virus getting into the cell itself. And so CCR5 is one of those receptors. And so this is actually a drug where you need to do testing beforehand to make sure that the virus is expressing that CCR5 molecule. If it is expressing that, then we can actually give this drug to prevent that connection from happening, and then you prevent the virus from getting into the cell. Okay, so this is really the only drug that we have that actually works on a human site and not necessarily at the site of the virus. And so basically it'll block up the person's CCR5 receptor and prevent that kind of that binding there and prevent the virus from getting into the cell. Over time, what you're going to find is that you will have virus that may be CCR5 positive that you can use this drug for, Maraviroc, and eventually it's going to get a mutation where it'll actually lose that CCR5, and then the Maraviroc is actually not going to be effective anymore. Right, so it's one of those things where you want to be testing kind of chronically. And how would you think you would notice if a patient developed resistance to a drug regimen? What kind of things would you see on their lab tests? CD4 would start to go down, and then what else? Yeah, viral is probably the first thing you're going to see. The viral load is going to start to pick up, right? Because CD4 counts really more of a sign of like immune destruction. So viral load would pick up first, and that would be a good sign that, hey, you know, something we're using here is not working. That would you know, initiate some resistance testing to see if they'd lost that CCR5 receptor binding spot. This drug is going to be pretty well tolerated for the most part, but again, you see some rash and hepatotoxicity. Really lots of liver issues you're going to pop up with most of these drugs you're going to see here.
What is CCR5?
CCR5 is one of those kind of co-receptor, it's one of those binding sites where the virus itself will, if it expresses that CCR5 ligand.
We have the receptor.
We have the receptor, yeah, on all of our CD4 cells. Yeah. So we don't lose that necessarily. The virus may lose that binding there, right? Yep. Okay. And then we have the integrase inhibitors. So we mentioned that. Do you guys remember what integrase does? Yeah. So this prevents that kind of integration of the viral DNA into the human DNA, so that way we're not producing the virus for it, right? And so we have drugs like raltegravir, dolutegravir, and then elvitegravir. Sorry, some of these newer ones they get increasingly hard to say because they just run out of drug names, and so they keep adding on more syllables to it, right? Just kidding. No, you can just say Viteca. That'll be easier. But that Viteca though is co-formulated with that cobicostat. Do you guys remember what that is? Just said it like 5 minutes ago. It's a 3A4 inhibitor, right? So this can boost levels of that, the drug, and then allow it to kind of stick around for longer, right? So again, binding to integrase and inhibiting that viral DNA from being incorporated to the human DNA. Again, this is probably one of the newer, probably the newest group of drugs that we're using for HIV, but rash, nausea, headache, so for the most part, pretty well tolerated as comparison to things like our protease inhibitors or like our NNRTIs. Okay, so looking at drug interactions, this is a very key thing to look at when you're looking at your patient and evaluating their med history. Some of them are going to be on purpose. I mentioned the ritonavir. It's used to boost levels up of other drugs. So very frequently you will see patients who, we talk about like a 3-drug regimen for HIV. Very frequently ritonavir is that 4th drug, especially if it's a protease inhibitor that's on board. You'll use that to boost levels. So they'll have 4 drugs for HIV, but one of them is really just using it for the drug interaction aspect. You can see some induction of CYP3A4, or I don't know what that CYO is, but it should be CYP3A4. But you can see things like the NNRTIs like efavirenz or etravirine that can actually induce CYP3A4. So it may lead to lowered levels of some of your other drugs, right? So keep that in mind. Also, you can run into issues because we mentioned that HIV patients have a poor immune system and they are at risk for developing opportunistic infections. So you worry about things like TB. TB regimens often include rifampin, and rifampin is going to do what? Induce and inhibit CYP3A4. Right, it's an inducer, right? It's a very, very important CYP3A4 inducer. So again, if you imagine if you had a patient who was on, say, a protease inhibitor that you're trying to boost with ritonavir, and then you had rifampin on board, it's not really going to be to the patient's benefit. So you have to consider those type of interactions and maybe switch them over to something else, right? Some drugs are going to have food-drug interactions. So again, I'm not going to list all those out, but just be aware they're out there. Some may need a more acidic environment to be absorbed. Some may need more fatty foods to be absorbed. Just make sure you look that up beforehand.
Do we just not do it, or do you dose your other medicine more frequently?
It depends on the patient, kind of what their resistance pattern looks like. It may be something where you switch them over to a different regimen that does not interact, so they can get the TB treated. It just depends. Yeah. some of those cases, especially nowadays that we have a lot kind of wider number of drugs to use for this, there's more likely to be another regimen you could switch them over to.
For the HIV or the TB?
For the HIV, yeah. Because the TB, TB we don't really have a whole lot of options for treating that. There could be some other, I'm trying to think. That's probably the most frequent thing to do, just keep the original TB regimen, then switch them over to something else as far as the HIV goes. Someone who does HIV all the time may have a different answer, so yeah, keep that in the back of your head. Apparently, I do not know everything. My wife has told me this for years, and I finally just, yeah. So again, just when in doubt, make sure you look up everything beforehand. Again, you may not be the people who are managing their HIV meds, but you may be managing them for other things, but their HIV meds are still going to be a constant influence there. So make sure you look it up beforehand. Okay, so again, treatment is ever evolving. Really need to look up the most current guidelines. The CDC will put them out as far as you go to, I think it's like AIDSinfo something. Just Google AIDS info. You will find the most up-to-date recommendations as far as what drug regimens are going to be preferred. But what we do know, again, and when do we start treating patients with HIV? At diagnosis, right? So as soon as you can measure the virus, you need to start treating that stuff, right? Because we want to keep that CD4 count as high as possible for as long as we can. But basically, you're going to see that, and again, this is all through a lot of experimentation, lots of different trials that we've done to find out what's the best regimen for these patients. And again, this is kind of a new disease state. Like, we've only been around for, say, 30, almost 40 years now. So we're still learning things, right? So initial treatment needs to be managed with a minimum of 3 antiretroviral agents, including 2 NRTI backbone. Okay, so that means like things like lamivudine, cidovudine, like bacavir, like those are all going to be your backbone. So 2 NRTIs, and then you're going to add on one of the other mechanisms, or drug from a different mechanism, right? So for instance, one of the more common ones that you would end up seeing is, say, like a protease inhibitor plus 2 NRTIs. So you may see something like darunavir plus ritonavir. Remember, ritonavir is going to be boosting that. And then you'd have tenofovir and imtricytidine. Tenofovir and imtricytidine is probably going to be one of the most frequent combinations you're going to see used out there. It is actually, it is a combination product that already is sold. It's called Truvada. So you may see that being used out there. We'll talk more about that a little bit later. But again, these are newer NRTIs that are used, that have better side effect profiles, so that's why they're recommended for initial regimens. And again, this is not taking into account the resistance testing that you're going to be doing for these patients as well. Okay, so these are initial regimens for someone who is treatment naive. Okay, someone who's treatment experienced, they're going to have a lot different kind of outlook based on the resistance. We'll talk about that in a minute. Yes?
Can you only use the protease inhibitors in someone who is treatment naive because of that single mutation?
That's for the NNRTIs.
Oh, yeah.
Yeah. Yeah, so with, and if you'll notice, if you're looking at the NNRTI regimen, they recommend, like, etravirine is a little bit more durable than that, but that's one of those things where, like, if you have efavirenz on board and that gets resistant, develop resistance to that, you pretty much lose a lot of the other NNRTIs. So if you're looking at the guidelines right now, and this is probably done like maybe a month or 2 ago, they're recommending either this PI regimen or they're actually recommending these integrase inhibitors much more frequently. And just to kind of give you an idea, like, this was not a preferred regimen with the integrase inhibitors when I was in school, and that was maybe only like 7 years ago, I guess, at this point. So these are constantly being updated, and so you may see something totally different in 5 years from now. But anywho, so again, with the integrase inhibitor plus 2 NRTIs, you have like raltegravir plus tenofovir imtricytidine, and then we mentioned NNRTI can be used as well, right? So that's usually the basis for any regimen is going to be 2 NRTIs plus some other mechanism. So PI, NNRTI, integrase inhibitors are usually the most common ones you're going to see used out there. Okay. Adherence is super important to this, more so than you see with antibiotic use, more so than any other kind of disease state, I would say, maybe not TB, but adherence is super important with this. And so variable adherence is very common. So we mentioned who are some of the at-risk population for developing HIV.
IV drug users.
IV drug users. How good do you think their adherence is? Well, there might be some well-meaning people out there, but they are frequently going to have variable adherence, right? Think about like the homeless population. Think about patients who may not have good health insurance, things like that. So adherence is always going to be a big problem. And so if you're going to undertreat it, you're just going to get more mutations. So we mentioned that reverse transcriptase is so sloppy at reproducing the virus that you're going to get more mutations. And so this is going to be a big detriment to our patients because, again, once they get resistant to something, like oftentimes they can't use that drug ever again, or in some case a whole class. So it's a very, very big issue. Other reasons you can have problems with adherence include things like psychiatric illnesses, substance abuse we mentioned, IV drug abusers. A lot of patients don't like the adverse effects, right? So if they feel so crappy when they're taking this and they felt better when they weren't taking any treatment, they may say, well, it's screwed. I'm just going to the virus isn't hurting me right now. I'm just going to keep going with this, right? Obviously, we know that's kind of a short-sighted kind of look at it, but and then also, unstable social circumstances, so housing, insurance, things like that can be problematic. In order to help improve adherence, we want to use combination formulations whenever possible. So, for instance, there's we have like something like Atripla, which is actually a 3-drug regimen that has the whole regimen just in one pill, which is very easy for them to take. Truvada I mentioned is very, very common. So there's lots of different combination products that help to reduce the pill burden and help to make adherence a little bit better. Right? Because I can't even take a multivitamin every single day. I can't imagine trying to take an HIV regimen that was like 20 pills in a day. But fortunately, it's gotten much easier for those patients. Also, it's going to help to limit some of the food restrictions as well, which can help to increase absorption and get better effect out of the drug. So I mentioned Atripla is one of the very common ones. That's an NNRTI plus 2 NRTIs there. Genvoya is one of the new ones, Complera. So different options you have in order to get the whole regimen in just one pill. Oftentimes it can just be one time a day too, which is very nice.
Do you get these at like CVS, or do these have to be mailed to you or something?
These are frequently, if you know you have a patient who has HIV and they're on one of these regimens, and you can have it like special ordered. A lot of hospitals will, or pharmacies will not carry these drugs naturally, but if they come in and they have an order for it, or a prescription for it, they'll say, okay, we'll go and order it for you. Oftentimes, a lot of these newer combination products are going to be very, very expensive. So again, insurance is like super important for getting this stuff covered. Yep. And again, frequently, it would be kind of cost prohibitive for hospitals in order to carry all these drugs, just in case you had a patient comes in on one of these regimens. So frequently we're using patient-owned supply for a lot of this stuff too. So think about it. Did the patient come into the hospital? They have their own supply of medication? If not, what's that going to do to their rate of resistance and things like that? So all things you have to consider, even on the inpatient hospital side.
What if they didn't bring it in?
What if they didn't bring it in? You got a family member that can bring it in for you, or can we go fill out at a pharmacy, or so there's lots of things to consider. Yeah. Because again, it doesn't make sense to carry a lot of these drugs on hand just for the chance that one patient comes in on that regimen. So there's a cost prohibitive kind of side from the healthcare providing side of it that kind of raises some questions, right? So you guys are the providers. You're like, well, I just want to continue the drugs, and the pharmacy's calling and saying, well, we don't have it. The patient's got to bring it in. A patient has unstable home life. They may not have access to meds. So you can see kind of the problems that kind of can creep up from these kind of patients, right? So, and again, in a lot of cases, I had one teacher who specialized just in doing HIV at a clinic, and she was like, if you're not going to take your drug 100% or 95% adherent, you might as well not even take it at all, because you're just going to end up getting more resistance to that. You're not really doing a good job at really inhibiting that viral replication. Because again, what's our goal viral load level? Undetectable, right? We don't want to be able to detect any virus, and so if they're having detectable virus, that means it's still replicating, it's still producing new mutations. Okay.
Is that bad for them individually or society or both?
It's more bad for them individually, right? Unless they're spreading it around to a bunch of people, right? And that can be a problem when you're looking at resistance patterns is a question of, well, who did you get it from, right? A lot of times you may not have the answer to that, and so if they were already carrying a very resistant virus, there's a possibility that they would have transmitted that over to that patient, right? So then you have to consider it. So that's why you oftentimes are doing initial resistance testing to make sure they don't have some kind of really resistant superbug, right? So all things to consider. Okay, so there are 2 different types of resistance testing. Have you guys covered this at all yet? Okay, this is super important for developing both, for treatment-naive patients who you're trying to make sure they don't have a resistant bug to begin with, and then for more treatment-experienced patients. This is absolutely going to be what guides you to choosing what your next regimen is going to be for these patients, right? So there's 2 types. There's phenotypic testing and there's genotypic testing. It's important to know the difference between the 2. Looking at the phenotypic testing, this is actually going to be determining the concentration of drug that it takes to inhibit 50% of that replication of that virus, right? So you guys remember when we talked in pharmacodynamics, we talked about things like effective dose 50, right? The dose it took to get 50% response out of half our patients, right? So same thing kind of here, this inhibitory concentration 50. And so basically what they're doing is they're comparing the results of the actual virus over to the wild type virus, or something that had no resistance whatsoever. And so you're kind of comparing to see what they're actually resistant to. This is really nice because it provides resistance patterns for like very complex mutations. And so it takes a lot longer to do. It's more expensive to do because you're actually taking the virus, the sample of the virus that the patient had, and you're actually testing with all these different concentrations of drugs in order to figure out what specifically it's resisting it. So it costs more, takes longer. This is going to be better though because it's going to tell you specifically when you have these interplay of different mutations what specifically the virus is going to be resistant against. Okay, so that's one way to do it. The other cheaper, easier way to do it would be genotypic testing. And so this is basically doing kind of sequencing the virus and seeing what mutations they have, and they have a big list of all the different mutations that we have documented. And they're saying, okay, well, based on this mutation and this mutation, it's probably going to be resistant to your NNRTIs. Okay, not as informative, right? Because you can't really take, especially with these treatment experienced patients, it's more difficult to find out, okay, well, what specifically are they resistant against because they have 20 different mutations that could be interplaying here. Okay, so phenotypic testing is going to be more informative, but it's going to be more costly, more time consuming. So, for instance, if I had a treatment naive patient, it might be easier just to do a genotypic testing, see what they come back as long as there's nothing kind of weird there. Then maybe you're good to go ahead and just use one of the kind of recommended regimens. However, if I had someone who had failed multiple therapies previously, has developed multiple mutations, or someone who's had the virus for a very long time, phenotypic testing is probably going to be better for them. Okay. So again, keep in mind the limitations of each one and which one may be appropriate for a specific type of patient.
This is done patient to patient.
Mm-hmm. Yeah, be individualized to the patient. Yep, absolutely. So pregnant patients, what do we do for pregnant patients who have HIV? Because obviously we want to prevent spread to the fetus. Basically, you're going to treat them the same as a non-pregnant patient, right? Obviously, we don't have a ton of information regarding randomized clinical trials, comparing pregnant women who got this drug versus not a drug. Obviously, you can't do that. But the thing we want to do is have maximal viral suppression to limit the exposure that the fetus has. So hopefully, the virus will not take hold in them as well. One of the drugs you do not want to use is going to be efavirenz because that can cause neural tube defects, right? So don't want to use that in those pregnant patients. Maybe switch them over to something else if they were looking to become pregnant or if they're at high risk for becoming pregnant. That would be something you want to avoid. This is avidine or AZT. That is going to be recommended intrapartum to actually prevent transmission. So basically what you end up seeing is that the mother will get zidovudine during the birth, and then for 4 to 6 weeks afterwards, the infant will then also receive zidovudine. The idea there is to try to prevent viral replication as much as possible, so that way you kind of eradicate the infection just with a natural immune system as best you can. Okay, and then also you want to avoid breastfeeding whenever possible as well. Okay, obviously that can be a big issue, especially if you're like in more developing countries, or maybe food and access to things like formula is going to be much harder to come by. You can see some of the problems that can come about from that. But yeah, so here at least avoid breastfeeding if you can. Okay, so chemoprophylaxis. So this is going to be important if you ever have the question, or maybe you guys are doing a procedure yourself and you end up getting stuck. What do you do, right? They mentioned my wife's friend's kid was playing at a park. He's like 2 and came back in at like an insulin pen needle that he'd accidentally found in the park and poked himself with. And he said, "Howie," it's like, ooh, that's like a parent's worst nightmare, right? You're just like, oh boy, what did that patient have? Probably not HIV, but how do I know? You don't really know, right? So chemoprophylaxis is super, super important. I can talk more about that in just a minute. But basically, we talk about things like pre-exposure prophylaxis and post-exposure prophylaxis. So most common that you might run into, especially in the hospital setting, is going to be something like post-exposure prophylaxis. My first rotation when I was in pharmacy school was at it was a Coumadin clinic, and my very first patient, we did point of care testing for the for INR. So basically, we would do finger sticks, and then we test the blood and get the INR right there. My very first patient I had to do had bilateral below-the-knee amputations, had HIV, Hep C, and had very, very thick calloused hands, and I was supposed to get blood out of this guy to try and test his INR. And let me tell you what, that was no fun, because I was like, I'm going to get HIV, I'm going to get HIV. I'm just trying to milk blood out of this guy's hand. Just like, oh. I did not get HIV or Hep C from that guy. I was just being a little irrational, but sometimes irrationality can play a role in some of these possible exposure cases. Also, if you ever want to have an issue getting warfarin dosed to the correct INR, have an HIV patient, because again, all those drug interactions, SIP interactions can be so difficult in order to get these patients on the right regimen. Anywho, so if you do have a possible stick or possible exposure to HIV, well, the question is, does the patient have HIV or not, right? So if you can get that status, that is a very good question to find out. If not, if you don't have access to the patient, you have to go kind of worst case scenario, right? And so in that case, you're going to go ahead and treat. So earlier the treatment, the better. So usually within 1 to 2 hours is going to be most beneficial. And so for those patients, the now recommended regimen is going to be tenofovir and entericidamine, which is that Truvada. That's going to be our 2 NRTI regimen, and then they actually put raltegravir. You guys remember what type of drug that is? No, that's one of those integrase inhibitors, right? So, so this is one of the new recommended regimen here. They'll actually do that for 4 weeks, right? So the idea here, and this will be very different than you would see with like post-exposure prophylaxis with like something like Hep C. We'll talk about that a little bit later in this presentation. But so this would be the recommendation. Again, start earlier because again we don't have a cure for HIV, so we can start earlier and prevent replication. That's going to be the best for this patient. Okay, so it's post-exposure prophylaxis when you've had a possible exposure to HIV. Okay. Next, we have pre-exposure prophylaxis. So this is kind of a newer thing, a newer concept, but this is going to be for patients who, men who have sex with men, because again, they are very at risk for spread of HIV. If you have serodiscordant couples, so you had one person have HIV and the other person did not, if you want to prevent spread, that would be one way to do it. IV drug abusers also would be another potential case here. And so basically these would be for, basically the patient would be taking daily tenofovir and entericidamine or Truvada, and that way they would be negative at baseline, right? So they get kind of initial testing. They do not have HIV, but if they're high risk for contracting it, they would basically take this every single day to prevent the infection from occurring. Okay, so that would be one of the other things that you could potentially see patients on. So again, if when one person had the HIV virus, they're being treated with their regimen. The person who did not have the virus, their partner may be on this every day, right? So even though they don't have the virus, they're trying to prevent the spread of it. Okay, so that may be another thing you'll see out there. Again, when I was in school, those recommendations didn't even exist. So this is constantly evolving as society is kind of adapting to HIV.
You take this and then you don't use condoms?
I would still recommend using protection, but again, high risk behaviors. Yeah, and it's hard to inject heroin if you have a condom over the needle. So, just kidding. See, you guys are awake. Yeah, so again, obviously protection is going to be the best thing to do for these patients, but this may be one way, especially if they're chronically at risk for spread of it. Then this could be something that could help prevent that from occurring. Right?
Don't they have to wait like 4 weeks or 8 weeks for the drugs to take effect before they can start having sex?
I'm not aware of that recommendation, but the drug should be effective as soon as they get kind of to their steady state. So. Yeah, as long as you're doing testing beforehand to make sure that they're negative, though, because that's the big thing. Because if they end up having the virus, and they just need to be treated as a normal HIV patient. Yeah. Okay. So looking at our outcomes, the things we're going to be measuring, we already mentioned, is going to be mainly CD4 count and our viral RNA load, the viral load. And so we do recommend doing that resistance testing at initiation. So oftentimes you can get away with the genotypic testing just to see if they have any kind of resistant bugs to begin with. You will typically want to monitor about every 3 months or so and see what the RNA is doing. Hopefully you want to get it to an undetectable level. That's really the goal here. Only reasons why you'd ever want to change regimens are typically if you have intolerable side effects. So they're just like, I just feel so crappy, I'm just not going to take it at all. Like, okay, well, let's look at using a different class of drugs to see if that'll help. If you have a treatment failure, so they're on kind of maximal therapy, they're saying that they're adherent, they're taking every single dose, but they still have viral RNA above 200 copies per ml, that would be another reason to change. Or they have documented resistance to the agents, right? So it comes back and says that, hey, they're resistant to the NNRTIs, switch them off of that immediately to go to another class of drugs that they're not resistant to. All right, so any questions on HIV treatment? Again, so be able to recognize an appropriate regimen, right? So we said we're always going to have a 2 NRTI backbone, either with an integrase inhibitor, protease inhibitor, NNRTI, something like that. Usually you'll see drugs like Fusion or Maraviroc. Those are going to usually be added on to more treatment experienced patients. Those are starting to develop resistance to other regimens or can't get maximal viral suppression. So you may see those in more advanced patients just based on the resistance patterns. Okay. Okie dokie. So next, we're going to look at opportunistic infections. This will not be all-encompassing, but I'll talk about some of the more common ones that you may run into, some of the more common ones you're going to see patients on therapy for. And I know you guys have covered at least some opportunistic infections before, right? Probably, hopefully this is some review. But anyway, so the main thing we're looking at before we had access to antiretroviral therapy, the main focus was trying to prevent opportunistic infections, or OIs, that were associated with kind of just rampant HIV replication and a lot of the CD4 count decline. Most of these organisms, that we're exposed to every single day, you can be exposed to PCP, and as long as you have a functioning immune system, you're not really at risk for contracting PCP pneumonia. But these patients obviously have, as their CD4 count gets lower, obviously they're less able to mount a response against that, and they're more likely to get the infection. So, for instance, you're looking at things like, okay, well, when are they at risk for developing PCP? Do you guys know the CD4 count? Yeah, 200 is the big one for that one. As soon as you start getting down to like around 50, like Mycobacterium, avium complex becomes a big one to worry about. And so, that thing to contend with, getting new infections, but you also have latent infections being reactivated. So if they had latent TB beforehand, this can become active, so you may need to worry about things like that as well. And so oftentimes you're going to see the recommendations for things like initial prophylaxis against an infection or secondary prophylaxis will be based on their CD4 count. Okay, obviously they have active infection, the treatment will change a little bit, but we're talking about more prophylaxis here currently. So anyway, so nowadays we're trying to make sure we keep the CD4 count as high as possible for as long as we can. We like to have as durable a response as we can, and hopefully we can help to prevent these opportunistic infections. So obviously we would like to vaccinate to prevent possible disease from occurring in the first place if we can. So make sure they're up to date on any vaccines they have. Obviously if they have a more competent immune system early on, they're going to have a better chance to get a durable immune response from a vaccine, so that's good to do. And then you're also going to be looking at their CD4 threshold. So as they get down to something like 200 or 150 or 100, that's when you're going to start to consider adding on some of these prophylactic regimens. We see the same thing in a lot of our chemo patients who become neutropenic, and we're also treating them for some of these same opportunistic infections, right? Because again, it doesn't matter what the pathophysiology of it is, like they're just immunocompromised. So in that case, they're very, very similar. Basically, after a patient has developed one of these opportunistic infections, we will give them, obviously treatment for that, and then there'll be secondary prophylaxis they'll be on as well for certain thresholds, and so you'll see that commonly. And then once they have a reconstituted immune system, so say for instance, you were treating them for prophylaxis of PCP pneumonia, but their CD4 count starts to rise and gets up to say 300, you would not need that prophylaxis anymore. So again, this is something you're going to be monitoring for. They may need prophylaxis for a while, but they may not need it later, and then need it again a year later. So just keep that in mind that those regimens can change. But this is not all-inclusive, but again, go to aidsinfo.nih.gov. That's the website where you can find all the guidelines. They will tell you up-to-date information on what is most recommended for different opportunistic infections, both prophylaxis and treatment. We'll go over a few here, just for some ones that are a little bit more common. Now, patients who have, especially more kind of long-standing HIV, maybe have not received medical care or gotten diagnosed, they could have opportunistic infections already kind of coexisting with HIV infection, right? And so, obviously, there are some benefits to kind of getting their immune system back, right? Because you want to try to get their CD4 count up to fight off that infection. But one of the things you're going to run into is that drug interactions can be problematic. Mentioned that with TB, especially if you have something that's like inducing CYP3A4, and then you also want to have a CYP3A4 inhibitor on board. That can have some difficulties getting the regimens right. Also, if you're trying to start a patient on treatment for TB plus, say, PCP pneumonia plus HIV, like that's a lot of drugs all at once. That can be very difficult from an adherence standpoint for those patients. The other thing you have to consider is this iris phenomenon. This is an immune reconstitution syndrome. Basically, if their immune system was not really that competent to begin with, and they get one of these infections, they can't really mount an inflammatory response. But if you were to give the HIV drugs and then allow the immune system kind of come back online, so to speak, all of a sudden you'll get a big cascade of inflammation. So the patients will end up feeling worse, but actually that's just them getting better, right? So from that standpoint, it's good to make sure you're educating them. But just be aware that you may need to treat things like fever and things like that. They're just going to feel pretty crummy, but eventually once they get over the infection, they should sort of feel better. Okay, so one of the big ones that you'll see a lot of chemoprophylaxis against is going to be this pneumocystis jirovecii pneumonia, or PCP pneumonia is usually how most people still abbreviate it. obviously the name can change, but it's still the same type of infection. But this is one of the most common life-threatening opportunistic infections for your AIDS patients. It's a fungus with the protozoal kind of characteristics, and we know that a lot of people end up getting exposed to it, but we don't really have any infection take place because we have competent immune systems. But the way that we're going to be doing this for treatment, oftentimes is going to be reliant on Bactrim or sulfamethoxazole trimethoprim. For treatment-wise, very frequently we have to, because these pneumonias can come in very, very severe pneumonias, you often have to start out with IV treatment for Bactrim, which is usually something we try not to use whenever possible, and then they can eventually be switched over to oral treatment for that. But this is the most common thing you'll see patients on for chemoprophylaxis, is they'll be on Bactrim. If you ever see like Bactrim, say like 3 times a week, or say like on Friday, Saturday, Sunday, or something like that, that's oftentimes going to be for prophylaxis against PCP. So we see that a lot in some of our chemo kids over at Nemours, but you may see that in HIV patients as well. Okay, so if you're kind of a weird dosing regimen for that, it's usually what it is. Okay. Yeah, and so the usually around CD4 count of 200, that's usually when we start to initiate prophylaxis. I'm not going to have you guys remember specifically the CD4 counts for any of that stuff, but I would remember that PCP pneumonia, Bactrim is going to be the treatment of choice for that, right? That's kind of things you want to remember. And then secondary prophylaxis is just going to be the same as the primary. Thrush can be another big thing that you worry about for these patients. Obviously, thrush itself is not going to be such a big deal, but what do you worry about with these HIV patients who have thrush? GI complications. Where can the fungus go after it gets in the throat? And then go to the esophagus, and then where can it go from there? Systemic, yeah. So you worry about systemic fungal infections, right? Because usually we can fight off fungal infections pretty well, but if you have a compromised immune system, you worry about these things going systemic, okay? And so sometimes oropharyngeal thrush may be the first thing you're seeing. You really want to make sure you nip that in the bud and make sure it does not become a more systemic problem, because they can be on antifungal therapy for a good long time, require hospital admissions, no good. You never want to have to pull a fungal ball out of a patient's lung. It's not really ever a good thing. They happen. It's not pretty. Anyway, so oftentimes for these patients, you may recommend, especially if it's more just kind of in the back of the throat, with something like nystatin. I mentioned nystatin before. It's an antifungal agent. Usually it is better for kind of acute treatment of thrush, mainly because it's not absorbed, so you don't have to worry about things like drug interactions and whatnot. But for more kind of progressive disease, especially if it's more esophageal, that's where you need to use something like fluconazole or diflucan. And if you guys remember, there's lots of drug interactions associated with that. It can help to inhibit CYP3A4, so that can be problematic for some other drugs. So again, look at their regimens, make sure you're kind of assessing for all that beforehand. But if you can, have them use nystatin to kind of switch and spit, that's usually going to be one of the best things for them to kind of prevent it from getting any further. This one, there's no real specific recommendation for prophylaxis. You just kind of treat as you see it. But a lot of times we'll have a lot of our chemo kids as well getting nystatin for prevention of this as well. So again, they're treated very, very similarly because their immunocompromisation is the exact same. Okay, lots of other ones that are out there that I'm not going to cover in super detail. You guys will get this in other classes, but things like cryptococcal meningitis can be problematic, toxoplasmosis. So all of a sudden, like, you really want to take care of cats. Probably toxo, right? So Mycobacterium avium complex, that can be a really, really nasty pneumonia that you may need to treat. That's usually when you get down to like something like 50 CD4 count, cytomegalovirus. So again, all these things, we've kind of covered the drugs used to treat those previously, so you just have to kind of recognize those as you cover those in other classes. Okay. So other complications of HIV. These patients are absolutely living for much longer than they used to. You guys remember when we were in epi-biostats, we were looking at that graph of HIV patients in the 80s, and you're looking to see like what the incidence versus prevalence was. Notice how like they all just died like by the end of the study period. Like so it was pretty bad back in the day. But nowadays we have much better regimens for this, and they're living much longer. And so now they're more at risk for developing all these complications, right? So most of them would die before they develop diabetes or heart disease and things like that. So you have to consider treatment for that as well. Also, long-standing HIV, you can see this nephropathy that can develop, so you do want to monitor for renal function. Doesn't necessarily affect a lot of their HIV meds because those are mostly metabolized to the liver, but could be affecting other meds they could be on. Obviously, cancers are a big risk here, and again, make sure you check your drug interactions. So again, if I have to put a patient on, say something like a calcium channel blocker like diltiazem or verapamil, you have to think, okay, well that's a CYP3A4 inhibitor as well. Maybe that could be affecting their HIV regimen, leading to side effects. Okay, so keep all those kind of things in mind. Make sure you run your interactions. Okay, next we'll come back and talk about STIs, specifically the most dangerous STI you can ever catch, the Subaru. Okay, we'll come back in 10 minutes. So we're going to talk about a few sexually transmitted infections, or STDs, however you like to call them. First one is going to be gonorrhea. So this is going to be a gram-negative diplococcus. It's kind of difficult to control. We see that there's a lot of asymptomatic individuals for this, right? So this is kind of the problem with a lot of these STDs, is that a lot of patients, especially male patients for whatever reason, tend to be more asymptomatic, and so it continues to spread, right? We end up seeing a lot of issues in patients who do not get treated. Obviously, you worry about things like pelvic inflammatory disease. It can lead to infertility if it's not treated. More systemic infections can occur as well. And then also what you'll see with a lot of these STDs is that HIV transmission is increased when you have kind of concomitant infections, right? So everything kind of spreads a little bit easier when you have some of these kind of stacking on top of one another. Okay, so kind of bad news, but to get these treated as much as possible. So looking at, again, look for up-to-date recommendations from the CDC. They publish these pretty regularly, so you may see things change from year to year. Currently, this CDC is going to be recommending only a single dose of IM ceftriaxone or Recefin. You guys remember what type of drug that is? Yeah, third-generation cephalosporin, absolutely. So just a single IM dose, 250 milligrams, is generally enough to treat most of your patients. They used to have offers for, or recommendations for oral cephalosporins, but they see that there's really just not as good of a response rate when using the oral drugs. They just say, let's just go IM, let's just do this one and done kind of thing. And what's the benefit of just using single doses for a lot of these treatments? Exactly, adherence. You have direct observed therapy. You know they're going to be adherent because there's only one dose and you gave it to them, right? That's a lot of the benefit here, because especially some of your high-risk patients, they may not be really good about going out and filling that prescription and adhering to therapy for a week or 2 weeks or whatever, right? So think about that. Also, you want to treat for chlamydia as well, because there's oftentimes going to be co-infection there, and this way you can just go ahead and get both of them done at the same time. So go ahead and treat both of these every single time together. So this is where you're going to see a single dose of azithromycin. Do you guys remember what type of drug that is? Macrolide, yeah, it's a macrolide. This one again has a longer half-life than something like erythromycin, clarithromycin. So this is where we can give just a 1 gram dose. You guys remember the usual doses that we give of 500, and usually 500 and then 250, you know, for the rest of the week. But yeah, so this is a 1 gram dose. We're giving a larger dose, this long half-life. By giving that, you're ensured to go ahead and treat that chlamydial infection as well. If they can't take azithromycin, then you can use something like doxycycline instead. But again, that's going to be less preferred because you have to give that for 7 days, right? And so we worry about compliance there. For patients who have a true cephalosporin allergy, and again, so really try to drill down and figure out what type of reaction they actually had. They say they're penicillin allergic, don't go ahead and just discount the IM Recefin, right? Very low cross-reactivity between penicillin, a true penicillin allergy, and cephalosporins. So in a lot of cases, you can go ahead and give the Recefin. You're probably going to be okay, but try to get the history first. Try to figure it out. If you can't do that, there's really not a lot of good alternatives for these patients. So you can use things like gemifloxacin, which we didn't really talk about extensively, but you guys can guess what type of drug that is. Yeah, it's a fluoroquinolone. And then IM gentamicin might be another option as well. What type of drug is that? It's an aminoglycoside, yeah. So IM gentamicin usually used for treatment-resistant gram-negative infections and things like that. Here you can use IM doses of that in order to treat the infection. So really try to use ceftriaxone whenever possible, if you can. If you were to have, say, like an infant who had a spread of gonorrhea, usually you worry about eye infections there. You can use topical erythromycin to go ahead and treat those, right? So these are for moms who maybe didn't have great prenatal care, or they have infection with gonorrhea or something, and it spread to the infant during the birth process. You can just use erythromycin to treat that. Yeah. Looking at chlamydia, so again, this is going to be one of the second most frequently reported STDs in the U.S. Behind HPV, which is human papillomavirus, right? HPV, right? So again, underreporting is probably going to be pretty common. Again, a lot of people are going to go undertreated, so it's probably actually twice what was actually reported there. So very, very frequent. Again, very asymptomatic. So you can see the previous slide. This is where we're going to use azithromycin as our kind of go-to for a chlamydia infection. Usually going to be treated along with ceftriaxone for the gonorrhea. Okay, so go ahead and just treat both of these. Patients who have kind of more extensive chlamydial infections in children, you may actually have to use oral erythromycin therapy for kind of more systemic therapy in order to treat that. They have kind of eye complications with that. There's another thing you might see for the kids. Again, sometimes for patients who have true macrolide allergy, they can't receive tetracyclines. Sometimes fluoroquinolones can be used, but generally, again, you want to avoid things like tetracyclines and fluoroquinolones in your pregnant patients. You do worry about some risk there, so just be aware of that. Okay, and next we'll talk about syphilis very quickly. I thought it was a very funny picture. Okay. So anyway, so this is caused by Treponema pallidum, again, a spirochete. What's kind of the problem with treating syphilis? Why can't we usually get away with like kind of short-term therapy for syphilis? Very slow growing, right? So you were usually with antibiotics and things like that, you're preventing cell replication. Here you see syphilis kind of grow fairly slow for the most part, and so you're going to typically need kind of more extensive therapy for the most part. We're talking about one kind of single dose option here, but very highly contagious, especially when you see like in the MSM population. I see a lot of spread there, and then you worry about things like more progressive systemic disease, things like neurosyphilis and things like that can develop, be very, very difficult to treat. Penicillin G is going to be our go-to drug for syphilis. And again, using single doses of something like oral penicillin is not going to work because you may not be able to get all of the replicating syphilis in that case because it is so slow growing. The thing we can use is a long-acting penicillin G. So you guys remember bicillin? You guys remember what you used that for previously? Sometimes you use it for things like strep throat and things like that. So again, preventing acute rheumatic fever for some of those patients. So again, this is nice because it comes as that kind of that milky white oil emulsion that you would inject intramuscularly, and has a very long half-life comparison to just like oral penicillin or IV penicillin. But so that would be recommended as single-dose therapy for kind of uncomplicated syphilis. Patients who have a true allergy, they may need to be on something like doxycycline or tetracycline for, say, 2 to 4 weeks. So you notice here how the treatment is much longer than you would see for some of our other infections, much longer than just 7 days. So 2 to 4 weeks there for treatment. And then if you did have more complicated disease, this is where you have to use things like aqueous penicillin G given IV. Oftentimes those are given either intermittently, very frequently, say like 4 to 6 times a day, or given as a continuous infusion, very frequent, just to keep the levels high. And you guys remember if penicillins are time or concentration dependent killers? They're time dependent killers, right? Because we need to keep the levels up above that MIC, that minimum inhibitory concentrations. Remember, anything you have to give continuously or you're giving very frequently, usually those are going to be time dependent killers, right? Things like fluoroquinolones, though, you just give once a day, those are going to be concentration dependent killers, right? So again, stuff that keeps coming back. Keep pulling back to the last semester, and you guys probably forgot it all. And then looking at herpes, so again, this is going to be one of the most common causes of genital ulceration in the U.S. 2 main types that we see is going to be HSV1 and HSV2. Usually you're going to see HSV2 for more genital disease, HSV1 for more oral disease, but again, that can be switched, and a reason one cannot go in either location. Another problem with this is you can have a high percentage of asymptomatic infections, and then you have viral shedding that can occur despite having no apparent lesions, right? We were talking about drug commercials yesterday, but you guys remember all those, Valtrex commercials, like even if you don't have active sores, you can still spread the infection. Like, so that's been drilled in my head from watching too much TV as a kid. But again, it's really important to make sure we identify these patients and educate them appropriately to prevent spread to other people. So goals here for treating genital herpes would be to relieve symptoms and shorten their clinical course, prevent complications and recurrence of disease if possible, and then also decrease disease transmission to uninfected people. Usually just for pain and discomfort purposes, or to treat that, things like warm saline baths, analgesics, antipyretics, all that can be useful to kind of treat those acute things. And then you worry about also making sure they have good hygiene, so that way they don't get kind of bacterial superinfections on top of that, right? So make sure they're not scratching at it and things like that. They can lead to secondary skin infections. So good hygiene can prevent that. But how we're actually going to treat this is going to be with antiviral agents, obviously. And so for the first episode infections, this is where we use things like acyclovir, valacyclovir, or famciclovir. So if the first two don't work, I got you, fam. Cyclovir. Yep. No, most frequently, acyclovir and valacyclovir get used usually 7 to 10 days or so. That's going to help to reduce that viral shedding, the duration of symptoms, and also the time for the actual ulcers to heal. So, tell you, my meme game is on point, guys. Anywho. Okay, so all patients really should receive treatment to help prevent kind of more prolonged symptoms, so that's going to be recommended for them. And we don't really recommend kind of topical products. So topical acyclovir is not really going to be so useful here. We need to kind of go oral systemic type therapy. For those patients who have immunocompromisation, especially if they have very severe disease, they will sometimes actually require hospitalization and IV acyclovir. I've seen very, very bad cases of HSV, especially in, we had one really bad case in the PICU back when I was doing my fellowship, of a girl who had HSV after organ transplant. She had a bone marrow transplant for secondary to leukemia. Obviously, you had to worry about things like graft versus host disease, so she's on a lot of immunosuppressants after that as well. She ended up getting a really nasty HSV infection, became resistant, and basically became really bad meningitis that basically looked like her CT scan of her head looked like, you know, moth had just been picking at the tissues. Very, very bad, very sad case. But those are the patients who may require things like IV acyclovir or even like kind of other antivirals we kind of alluded to, things like foscarnet and other things that you don't use too often. But remember, when you're using things like acyclovir, you worry about renal toxicity, so you want to make sure they're well hydrated, because otherwise that can precipitate out and crystallize in the kidneys, leading to acute kidney injury. You also worry about some CNS toxicity and some bone marrow issues there. Okay, so those are the main things you worry about with things like acyclovir. For more recurrent infections, so you can have kind of two different kind of mantras for how to treat these HSV infections. You can have either episodic therapy, which you would only use to treat once symptoms begin, or if they have kind of like a prodrome of symptoms and they know they're about to get an episode, they can go ahead and treat at that point. Or you can just have chronic suppressive therapy, where they're just kind of chronically on the medication constantly. So basically, for episodic therapy, basically they're starting 6 to 12 hours before symptoms begin. And really no more than 24 hours after, right? Because anytime you're dealing with viral infections, the earlier you can treat, generally the better it's going to be for preventing kind of continuous spread of the virus. So these are going to be better for patients. The kind of episodic therapy is better to have prolonged recurrences, or if they have more severe symptoms, they tend to do better with this type of therapy. And keep in mind, though, they can still spread. They can still have viral shedding even without an active lesion. Okay, so that's kind of one of the drawbacks to using episodic therapy. On the other hand, if you have chronic suppressive therapy, this actually reduces the recurrence. Again, they're taking it every single day. To reduce the recurrence pretty significantly by about 70 to 80% for those patients. And then you have less asymptomatic viral shedding. And so we don't know necessarily the full extent of how this is going to affect unaffected partners yet. But this is probably going to be where we start moving more towards more chronic suppressive therapy, I think, in the long run, as we get more evidence with it and more trials and things like that. Okay, next we have trichomoniasis. This is a common vaginal infection, so it's a protozoa, and so we're going to use a different type of drugs for this. Oftentimes men are going to have a spontaneous cure rate that's usually pretty high, but you also see a lot. Usually females get treated for this because, again, guys are spontaneously recovering, and guys are going to spread it more to females anyway. Treatment for this is mainly going to include antiprotozoals, so metronidazole is going to be a big one, right? Any big food interactions you worry about with metronidazole? Yeah, alcoholic. You get what type of reaction? Right. The disulfiram reactions, no drinking there. Do you guys remember the mechanism for that interaction?
You don't have aldehyde dehydrogenase.
Yeah. You inhibit the aldehyde dehydrogenase, so you get that acetaldehyde buildup. That's what causes the flushing and the vomiting and all that bad stuff, right? So metronidazole is probably your go-to drug for that. Tinidazole is going to be another drug that potentially can work as an antiprotozoal, work to damage the DNA there. Again, this is going to be nice because you can utilize single doses of therapy. So usually like a 2-gram dose of either drug is enough to go ahead and eradicate the infection. Yes.
The disulfiram reaction, does it happen with the tinidazole?
Not that I'm aware of. Even the metronidazole is probably a very tenuous kind of link with that anyway. It's kind of one of those medical dogma things that I don't know how often it actually happens in real life, but we still recommend not combining the two anyway. So, anywho, it's just an aside. But again, this is one of the things where treating the partner oftentimes is going to help lead to a better cure rate. So again, those patients may be asymptomatic, so oftentimes you can recommend treating both the patient and then also the partner just to get spontaneous or to get cure for both patients, right? So that way they don't keep spreading them back and forth to one another. Okay, so any questions on sexually transmitted diseases. You guys are all going to just study it all spring break long. You won't have to worry about any bad diseases or anything like that. No disulfiram reactions, right? No one's going to be drinking during this week, right? Okay. Yes. I think your word counts for little, but no. Okay, so next we're moving on to hepatitis. So we'll talk about A, B, and C. Are there other types of hepatitis? D, E, yeah, there are other types. We're mainly going to talk about A, B, and C. Those are the main ones we're concerned about treating for the most part. C has probably had the most changes as far as therapy goes, because can you cure HIV? Not yet, but can you cure Hep C? Now you can, right? Used to not be able to, but now we can. So that'll be kind of one of the big changes we have here. So I had to learn all about new Hep C treatments just recently. So it's good, up-to-date information. Anyway, so hepatitis A, this one is usually self-limiting. How do you normally get hepatitis A? Yeah, food, specifically fecal-oral transmission, right? So rarely is it going to be fatal. Usually patients are able to kind of overcome this pretty easily. But we do see decreased occurrence of this mainly because we have vaccinations now. So we can get rid of vaccinate patients against Hep A, and that helps to prevent a lot of that. Obviously, good hand hygiene is one of the better prevention methods here as well. But it's pretty tough, if you're dealing with small children, everything goes in their mouth. It doesn't matter what it is, whether it's dirt or poop or anything like it just goes in their mouth. So again, sometimes the good hand hygiene can be difficult to manage in those patients. But fortunately, though, once they acquire the infection, usually it's going to be self-limiting and does confer immunity post that. So again, they don't really worry about it getting it a second time. So most patients, again, will resolve within 6 months, majority of doing so within 2 months or so. But obviously our goals here are to prevent the infection from occurring in the first place if possible, and then otherwise, it's mostly supportive care for these patients. Really don't have a lot of other good meds to help manage that. But two main vaccines we have here are going to be able to protect against that, something like Havrix and Vacta. Usually it's going to be recommended for children at 12 months of age. We'll talk more about vaccinations later on in the course, but how come you don't think we vaccinate earlier?
They're not eating. They're not eating milk.
We still eat. Again, think about the immune system for infants and newborns, right? Is it fully developed? Not yet, right? So a lot of times they may not be able to mount a full immune response and really get the full immunity against that. So that's why you're going to see some of these are going to be delayed a while because they may not be able to get full efficacy out of it until that time point. So they are, somewhat at risk, during that initial 12-month period. But again, washing your hands after changing diapers, food prep, all that can help to reduce transmission there. For some patients, you may see an immune globulin being used for post-exposure prophylaxis. Basically, we're giving exogenous pooled donor immunoglobulin, giving to the patient. That kind of helps mount an immune response for them. It's not very common that we do this, but especially if you had a very young patient, a very old patient, or those that are immunocompromised, those may be candidates to get immunoglobulin therapy to kind of help give their immune system a boost in order to help treat that infection, get rid of it. Okay, Hep B is going to be a little bit more interesting since we have some drugs for this. This one is very highly infectious. Do we have a cure for this one? Not necessarily. Some patients are going to be able to kind of overcome it on their own, but we do have vaccines. Yeah, we have vaccines to prevent this as well. So, so my wife's friend, whose kid was 2-year-old running around the playground, found the diabetic pen needle, insulin needle, had came back up and said, "Owie." One of the big things you were worried about, because again, you don't have that patient there anymore to determine what their status was for any kind of disease. This is one of the things they actually ended up giving post-exposure prophylaxis for, because the child had actually not been vaccinated against Hep B. Mom had some vaccination issues and things like that, so she had not vaccinated her kids against Hep B. So we'll talk about some of the treatment for that in just a minute here. That's one of the things they did cover for it. But again, a lot of patients are able to kind of overcome this on their own. Some are not, and they're going to have kind of more chronic infections. So this can lead to things like hepatocellular carcinoma and things like that. And so actually vaccines against Hep B is one of the first things we had a vaccine against to prevent cancer, right? You guys think of any other vaccines that can do that? And Gardasil, which is for HPV, right? So that can prevent cervical cancer, right? So that would be one of the other cases where there's a vaccine that can prevent cancer. But again, when we're looking at patients, those that, as far as spread goes, obviously can be spread very similar to lots of other communicable diseases, but perinatally is going to be a big spread as well. So if the mom's not being protected against it, or she has an infection, spreading it to the child is going to be a big risk there, which is why very frequently, kids are given their Hep B vaccine, right around the period of birth, right? So patients who have kind of persistent antigen levels greater than 6 months are considered to have chronic HBV, and at that point, cure is not really going to be possible. So you're going to see this more of those perinatal infections that do not get treated. Okay, they're going to develop the chronic infection, just have to live with that at that point. So again, HBV vaccine, mentioned that protecting against human cancer. You will see that some patients will be managed both with the vaccine and then also with hepatitis B immunoglobulin. So in that case, I was mentioning, that child ended up getting both first started their vaccine, and then they also got a dose of the Hep B immunoglobulin, because that is one of the things that is so easy to spread. Some patients may have that and not even know it. He went ahead and got the immunoglobulin to help prevent against that. I'm not going to have you memorize all the brand names for the vaccines. They change, and there's lots of different combination products that are out there. So just be aware of that. Usually vaccines, Hep B specifically, requires 3 doses. Why do you think it requires multiple doses to get immunity? All right, so we'll talk about that in the immune section, vaccine section later on in the course. But basically, you have to kind of re-challenge the immune system periodically in order to help develop this durable response, make sure your body can respond to it later on in life. So it kind of helps to stimulate natural immunity. And so some drugs, some things you can get natural immunity just with 1 dose. Some of them require several doses. And so Hep B is going to be one of those ones that require multiples. Okay, so our goals of treatment, if they do have kind of a chronic infection, we'd like to have maintenance of that viral suppression to prevent, some of the complications of, hepatitis and cancer and things like that. We would like to have seroconversion to this anti-HBe antigen and loss of the HBe antigen. They said it's one of the proteins there, the envelope antigen there, and then prevent progression of those kind of more chronic complications. Basically, how do we decide who gets treatment? Many patients end up undergoing kind of serial monitoring for their hepatic function, and some patients will actually wait until they develop kind of more severe disease. So some will look at their LFTs and say, okay, once you get above a certain level, this is when we're going to start treating you. Decision to treat is mainly going to be related back to their risk of liver-related morbidity and mortality. Okay, so if they're high risk for developing further liver disease, you might go ahead and decide to treat at that point. So if they're chronic alcoholic or something like that, that may lead you to want to treat earlier rather than later. So here's just like a sample algorithm, what you might see. So a patient who is at that threshold, they have that Hep B virus, and they're positive for that antigen, the surface antigen. Say you may hold off on treatment until their ALTs get, say, above 2 times upper limit of normal, right? So once you're at that point, then you say, okay, at this point we should go ahead and decide to treat, and we'll talk about these drugs that we use to treat in just a minute here. So one of the first group of drugs, we mentioned these previously when we talked about multiple sclerosis, but this is our interferons that are come back here. Do you guys remember any side effects from interferons? Mood's a big one, right? So you're going to get extra moody when you're on this drug. Increased risk of depression, suicidality, things like that can occur here. These are really nasty drugs, but basically what they're doing, and this is one of the first treatments we had for HBV infections. This also was a big component of HCV treatment for a long time as well, but we'll talk about some of the newer drugs for that. Basically, it's just kind of stimulating the own host immune system. Works as kind of immunomodulator to help increase activity of the host immune system against HBV specifically. And so the problems with these drugs, again, it requires multiple injections throughout the week. So again, 3 times weekly injections can needed here. A lot of times you're going to see pegylated forms of this drug being used that end up given less frequently. So once weekly peg interferon can be given rather than 3 times weekly. So it can be a lot better for your patients. Also, you can get some better efficacy out of it and suppressing the virus load. But I mentioned lots of adverse effects, and so you worry about one infection in decompensated cirrhotic patients. It's kind of poor decompensation already. This is where you want to maybe avoid using interferon at the time until they kind of recompensate for themselves. And then lots of black box warnings for interferon. Worry about things like neuropsychiatric issues that can pop up, autoimmune conditions, ischemic conditions, infectious disorders. You have anaphylactic reactions to it. So all these things are super bad. We like to avoid using this drug whenever possible. So that's why vaccination is so super important. Make sure you don't get HBV in the first place, right? We don't know the optimal time for therapy, but some patients will receive this up to 24 months to see if they can kind of help stimulate and clear that infection. Some other drugs we can see being used, like lamivudine. We saw that back in the HIV section. You can go check that out. Again, this is working as an NNRTI, has activity against HPV, and so sometimes will be used, if you had a patient with concomitant HPV plus HIV, this might be a good drug to use in that case because you can kind of get double activity out of that. Usually, it's not going to be recommended first line just due to risk for things like relapse and resistance developing can be an issue there. Some other drugs you can use, antivirals, include adefovir. Works very similar to lamivudine, so it kind of works to block kind of chain or DNA elongation for the virus. So this maybe will be used for patients who develop resistance against lamivudine or something like that. And a couple other drugs you may be using. Occasionally you have things like entecavir. Most of these are going to be used for patients who are resistant to lamivudine. You kind of step back and use it. So if you can't use interferon, then this is where you kind of start to use some of these other antiviral agents. Lamivudine is okay, but you get resistance to it. This is where some of these other drugs come into play here. Things like entecavir, talbivudine, tenofovir can be used as well. Okay. Tenofovir may get used instead of lamivudine in some cases. Sometimes better tolerated. Okay, so then moving on to Hep C, this is going to be probably the biggest amount of new information as far as drugs go in this case. Basically, we have a lot newer therapies, and so actually one of my wife's friends actually ended up, he was coming from, I think, Vietnam as a child. So his parents were kind of, moved over here, and so he immigrated and actually ended up contracting Hep C due to kind of improper sterilization of medical tools and things like that. So, contracting that, didn't realize it until he was probably in his mid-30s, right? So it was one of those cases where we're just like, man, it sucks. He's going to be on chronic Hep C therapy for a long time, but nowadays we have this newer direct-acting antivirals that we have. He actually ended up as a cure now. So we talked about getting these cure cards that basically you get and saying, when you actually clear the infection, say, here you go, you don't have Hep C anymore. So it's kind of a cool thing. Now that we have curative therapy for it. So we'll talk a lot about those and how those are working and just how expensive they are as well. So pretty expensive therapy. But a lot of acute cases of Hep C end up going on to produce chronic infections. Generally, a host immune system is not going to be strong enough to really clear the infection itself. Not only that, you have kind of rapid viral diversification, which can make it more difficult for the person to clear the infection on their own. So our goal here nowadays is going to be to eradicate the infection, so we can get virologic cures now, which is great, and then we want to have a sustained virologic response. So oftentimes we're measuring HCG RNA levels. You want to make sure that they're undetectable for at least 12 weeks after the end of treatment. So we want things you can go back and monitor for to make sure they stay negative from that standpoint. And then obviously, if we can't clear the infection, prevent complications that arise from that. Treatment is going to be recommended for all patients, basically to prevent those complications from occurring. And baseline testing usually needs to be done to determine the duration of therapy and the response to therapy. So because there are several different genotypes for Hep C, we want to make sure we're using the right drugs for that. So we'll talk about that in just a second. So again, previously the treatment had lots of side effects because it required use of interferon therapy. There's also another drug we'll talk about a little bit later called ribavirin that has very similar side effects, also very nasty for patients to take. I mentioned my wife's friend would get, you could tell when he was on interferon just because his mood would just be much more aggressive and just kind of have a lot shorter fuse in a lot of cases. So it's kind of very insufferable for his wife and things like that to deal with when he was on therapy. But it's like that, or you go on and get cirrhosis, so you kind of take the good with the bad. But nowadays we have therapy that we can get a cure within 12 to 24 weeks, and it's going to depend on the viral genotype. There are types, GT1 through 6, different genotypes of the virus. You're going to find that 1A and 1B are most common in the U.S. That'll be important because you're going to see that some of the newer drugs, they only will work on certain genotype. So one may only work for genotype 1 and 3, some will work for 2, 5, and 6, so it's important to know what type they have at baseline to make sure you're using the right drugs. So these are the direct-acting antivirals. Essentially, when the Hep C virus is replicating very similar to HIV, they produce these nice long protein strings, which you can see here of kind of inactive proteins. So things like NS3, NS5A, things like that. Once they're eventually going to get cleaved into the active protein sections where they can start to replicate the viral DNA. And essentially, you're going to have different drugs that are able to come in and inhibit different parts of this. So some will prevent this kind of breakup of the protein string. Some of them work to directly inhibit certain proteins, and you're going to get basically prevention of replication of that Hep C virus. We'll talk about some of the different sites that drugs are working at next. So I will say right now that these drugs are hard to say. They do not really roll off the tongue very well. So you'll have to forgive my pronunciation. Latazivir or Declenza. This is going to be effective against GT1 and 3. Okay, so this will be good for ones in the U.S. because again, a lot of people have either type 1A or 1B. This is going to be useful for that. I'll show you a table in just a little bit later that will kind of divvy up what genotypes the different drugs are going to be effective for. I'm not going to test you on that specifically, but we'll talk about things like mechanisms, drug interactions, adverse effects, things like that you should know, or at least be familiar with these drugs. Okay. So this one specifically is working by blocking the viral RNA replication and the actual assembly of the virion by binding that NS5A protein. So just like in that picture we showed just a second ago, binds to that, prevents the RNA from actually replicating. Basically just distorts the protein, changes the conformation, is not able to really have its same function like it used to. A lot of these are very nice because one, they are oral. So all these new drugs are going to be oral in nature, which is great because before they were using interferon and ribavirin, and interferon had to be given subcutaneously by injection, which is not good for a lot of patients. And so also you don't see a lot of organ impairment problems. So again, if you already have kind of chronic issues with your liver, a lot of these can be given without kind of regards for that, which is nice. They also are very well tolerated. Really not a ton of side effects associated with most of these. Some nausea, diarrhea, headache, nothing the patient cannot tolerate as compared to what you'd see with like interferon. The thing though you have to consider is it's going to be very, very expensive, $20,000 a month just for this drug. This is a pretty recent prices I just checked out maybe a month or two ago. And again, how long do we need to treat for? Like 12 to 24 weeks, right? Depending on, so at a minimum 3 months you're having to treat them for. So that's $60,000 right there, maybe $120,000. Okay, so very, very expensive. But again, what's the cost of having a patient go and develop cirrhosis and need a liver transplant? Many, many times that. So in a lot of cases, it makes sense for insurance companies and things like that to cover this because once you get cured, then you're done. You don't have to worry about it again, right? You have this ledipasvir and sofosbuvir, sorry, it's Harvoni. This one is going to be a combination product that's working against a wider array of genotypes. You have 1, 4, 5, and 6. You'll see that the ledipasvir is going to be inhibiting that NS5A protein, similar to that Declenza we just saw. And then this sofosbuvir is going to be actually a prodrug. You guys remember what prodrugs are? Be activated, right? They're actually going to be inhibiting that the RNA polymerase, the NS5B polymerase, and so basically it's acting similar to what we saw with our NNRTIs, where they acted as a chain terminator. Once it gets incorporated into the RNA, you can't elongate the RNA any further, and so then you can't really do anything else. You may see that one being used alone by itself, added onto some other regimens. I'll show you a table of that just a little bit later. Again, no organ impairment you have to worry about, which is nice. Again, very well tolerated. So this one is, again, about $30,000 per month. So a very, very expensive meds we're talking about here. Is Semeprovir or Licio. This one is inhibiting the protease NS3-4A. So this one is actually responsible for cleaving that string of protein in order to get the functional components of the virus. So by inhibiting that, very similar to your protease inhibitors we saw for HIV, you prevent the actual functional maturation of those. Again, this one is not used by itself. Very frequently has to be added on to other things. So you may see it being used in combination with like sofosbuvir or added on to, say, interferon ribavirin therapy, depending on the genotype and what kind of resistance patterns the patient has developed already. You have Betassavir. This is an NS5A inhibitor, again similar to Declenza. This one is often given in combination with either Paritaprevir, which can inhibit that NS3-4A protein, or it actually can sometimes be given with ritonavir. And so it's kind of a 3-drug regimen. That ritonavir is again used as a 3A4 inhibitor, so it boosts up levels of that paritaprevir. And so this regimen is either given with or without dasapuvir, and so you'll see some different combination products. And again, it's all related back to what type of resistance the patient has already developed, especially if they have kind of long-standing infection, or if they have certain types of certain genotypes. Okay, and then the last drug in this group we called ribavirin. Again, this is an older drug, but it was used a long time in combination with interferon to have kind of chronic suppression of the Hep C virus. We don't know the full mechanism of this one. It's thought to be somewhat immunostimulatory. It's thought to lead to also this RNA mutation to a point where the virus cannot continue mutating and just leads to kind of this error catastrophe that prevents replication any further. A lot of adverse effects with suicidal ideation, depression, insomnia. Like you're already depressed about having Hep C, and now you have these other drugs that are just worsening that. So you can see some kind of issues with that. And then you also worry about things like hemolytic anemia, so also be very problematic. This one was also pregnancy category X, so you had to be, consider the fact of whether or not your patient wanted to get pregnant anytime soon. So, for instance, females, they recommend actually using 2 forms of birth control for up to 6 months after you even discontinue the ribavirin therapy, just to prevent any birth defects from affecting the fetus. Right, so it sticks around for a good long time, so it's kind of problematic for a lot of them. Okay. But if you're using some of the newer agents, again, you should give them their 12-24 week course of therapy, and they're cured, and then you don't have to worry about pregnancy at that point. So it can be much better preferred by your patients. Okay, so how do we treat this? Basically, ribavirin will be used for difficult to treat patients. So mainly if you have prior treatment experience or if you have kind of underlying cirrhosis, those would be patients who would be more likely to receive ribavirin to deal with that infection. Pegylated interferon definitely has gone down in use very, very substantially, which is a good thing. So it's kind of a nasty drug since the direct-acting antivirals have developed. So now those are much more commonly used nowadays. If the patient has cirrhosis already kind of that kind of chronic damage to the liver, it's going to be more difficult to achieve that sustained virologic response. So in that case, they may be more likely to use things like adding on ritonavir in addition to using some of those DAAs. Okay, and then some of them do need to be adjusted based on liver dysfunction. Most of them no, but if you were to use something like that onbedazovir, paritaprevir, and ritonavir, those would be a combination where you want to look at the liver function beforehand, and you can adjust the dose as necessary. Okay. Treatment experienced patients, so those who maybe have been receiving ribavirin and interferon previously, they do require longer use of treatment. So maybe more on the 24-week scale, and then also use of ribavirin can be useful here. And then you may want to consider doing resistance testing to figure out if there's any drugs they would not be responding well to. If you do have an acute exposure to Hep C, so for instance, as mentioned, my wife's friend's kid who had that stick. Basically, for them, because now we have a viral cure for that, we do not give kind of post-exposure prophylaxis. We will actually go ahead and wait until they develop a detectable viral load, and then we can treat at that point if they do develop it, because a lot of patients will clear the infection spontaneously, about 50% of the time. And of course, any issues with compliance, if you're not taking the meds as appropriately or as you're supposed to, any delay can lead to resistance and failure of the therapy. So that's a big thing to let them know, especially if they're paying $30,000 for a month for some of these drugs, and make sure they take it appropriately. And so you need to make sure they have some kind of plan to make sure that they can receive the drug every single month. So again, if they're a homeless patient who has very sporadic access to care, like they may not be the best person to receive some of these therapies, right? If they have good, kind of stable social support, and they can make sure they get it every single month and take it, and that's best for them. Okay, so this is a handy chart, I think, to kind of give you an idea of how you would end up treating some of these patients. I know it probably looks like a lot of gobbledygook to you guys right now, but it can be very handy just to kind of reference back in the future. But looking at something like type 1A or 1B, which we mentioned is most common in the U.S., you can see here that for patients without cirrhosis, 12 weeks of therapy is usually going to be enough in order to treat those patients. But when you're dealing with a cirrhotic patient, someone who already has resistance, that's where you need to look to treat for longer, usually 24 weeks, and that's where you add on things like ribavirin as well. Okay. Again, in some cases, you have like GT type 3. Notice there you use pegylated interferon. Obviously, we like to avoid using interferon, ribavirin as much as we can, but for some of those more resistant patients, that's what you have to use. Okay, so any questions on this section?
As far as genotypes go, what do you want us to
know? Know that you need to test beforehand to make sure you know what type you're dealing with. That's probably the extent of it, right? It's good to know that 1A and 1B is probably most common, but I'm not going to ask you that factoid specifically on the test. But I may say something like, okay, patient is being treated for Hep C. They have cirrhosis, it comes back as GT type 1A. I probably wouldn't even put the genotype in, but say, a patient has cirrhosis, what drug may you need to add on, or how long would you need to treat for? Things like that would come up on testing questions. Any other questions? All right, I will see you guys Thursday.